So those are some good cases, I think, and what I want to talk about next is how do we implement this protocol into practice, and what are some of the challenges and what are some of the ways to get around that. So this does bring us to our next polling question, and so what I'd like to do is for the attendees is to ask, what do you see as your biggest challenge to implementing OPTALYSE protocol within your practice or your health system? So we'll give you some time again to respond to this. So it looks like we had about 33% of the attendees said that convincing my colleagues the protocols will be effective. 28% said that there was challenges in integrating it into the existing protocol or your current PE program. Only 3% said that incorporating into the IT system would be a challenge, and 31% said getting more referrals to treat submassive. So really a fairly equal split between trying to convince your colleagues that these protocols are effective and integration into your current treatment protocols. So I think that's certainly were some of the challenges I think that we had as well when we started offering OPTALYSE as really our standard of treatment. But as we'll talk about, I think it's the key is really collaboration, not only amongst your colleagues, but amongst the different departments. This was a very similar slide that I would show when we were talking about implementing Seattle 2 protocol. And I think some of the lessons of implementing Seattle 2 hold true for OPTALYSE. And just like we did for Seattle 2, when myself and my colleagues wanted to implement this in our own health system, we went around to all these different departments, to pharmacy, to the CCU, ICU, to the ER. We talked to all of our interventional colleagues, and we explained the protocol. We showed them the data, and that's I think really important when you're trying to implement something like this, especially in a place where you may have already existing protocols. So this really would just fit nicely into, what we say is our tools of the trade when you're offering advanced PE treatments. And now with OPTALYSE, I think this just gives us much more flexibility in what kind of patients we may offer this to, and how we keep these patients in the ICU setting. So this is really our story of how we started with PE therapies and implementing OPTALYSE, and it was really just one person initially, and then our PE treatment team grew to 7 interventional cardiologists and 5 interventional radiologists offering PE therapy in 3 hospitals. So just like with Seattle 2, is we had to go to each of these operators and explain the protocol, explain the data, show them the results, show them the safety profile. That was really important for us, especially when we have multiple specialty program. You may be a single operator, you may be just one of 2 or 3, but I think the lesson is still there, that you really have to share these protocols and awareness with your colleagues who are offering PE therapy. This was our OPTALYSE experience. I only show this to point out that we really did treat all cohorts when we were participating in the trial. We actually had quite a few patients in the 2-hour, 4-hour infusion arm, and all these patients did well. I can still very clearly remember when we began randomizing into the 2-hour and 4-hour treatment arm that these patients would get treated, the catheters would get placed, they go up to the ICU, and by the time you would be done with your orders and dictating your notes and checking on the patient, their infusion time would be done, and we felt quite comfortable getting them out of the ICU that same day. So I think part of this is a comfort level. That certainly was our lessons that we learned from this, is that these patients with this low lytic dose and duration really do well with this type of therapy. It's hard to implement a protocol like OPTALYSE unless you have a standard concentration of dosing, unless you work closely with your pharmacy. So we've worked very closely with our pharmacy, and what we do with our concentrations is that we will use a 50 milligram vial of OPTALYSE, and this will get concentrated into 12.5 milligrams in 125 cc bags. There'll be 2 bags that will be sent over for each patient. As you can see here, this is essentially our order set. We have 2-hour, 4-hour options, 6-hour options, and the concentrations again are the same, and makes it very easy to adjust the pumps and drips to which OPTALYSE treatment arm that we want to use for these patients. So looking at submassive P treatment, when we were talking about Seattle 2, we were excited about such a lower lytic dose. 24 milligrams felt low, and OPTALYSE now is showing that even lower can be just as efficacious and as safe with a much lower lytic dose and a much shorter duration. I think the scales are really certainly tipping more towards a lower treatment approach, certainly for us and in our experience, since we now have been doing OPTALYSE protocols since the beginning of the trial, and then with the closure of the trial, we've adopted this as our standard approach for treating patients. We see benefits in the flexibility, as I mentioned, with same-day ICU stay. We see the benefits of this and flexibility of offering this to elderly patients who we may have had much more pause or caution or equipoise, and we have the flexibility to look at this in even some of the post-operative settings that we, again, may not have considered. So I'm going to end on this last slide, and these are just some top 10 OPTALYSE and PE protocol considerations. So certainly number 1 would be make your referring and interventional colleagues aware of this therapy. We saw from the polling and from the surveys that referring physicians are more likely to refer more cases to you with their awareness of OPTALYSE and lower duration and lower lytic dosing treatment options for these patients. Certainly, EKOS and OPTALYSE is designed for the submassive P population. This is massive P. Continue to give IV thrombolytic therapy if indicated. Cross-specialty collaboration and coordination, again, extremely important when implementing protocols such as OPTALYSE. Having conversations with the various departments in the hospital and awareness with your interventional colleagues is, again, really important, as is standard TPA concentrations. It really makes adjusting between different OPTALYSE protocols easy, and it makes it easier for the nursing staff to adjust the pumps and the infusion rates. Certainly with talking about P, we should always mention avoiding the misdiagnosis of the PE masqueraders and RV infarction, aortic dissection. Make sure CT scans and EKGs are done on these patients, and you would be unlikely to have that occur. Early morning start time, again, I think is really complements OPTALYSE protocol very well. We try to do these cases early in the morning with these 2 4-hour, 6-hour infusion times. You will be done. The TPA with its short half-life will be out of the system, and you can safely transfer these patients out of the ICU. Use caution when treating older patients. Certainly, the data, it holds true for not only IV and catheter-based lytic therapy and even for anticoagulation, that older patients do carry a higher bleeding risk. I think these are the patients that I certainly would consider OPTALYSE protocol in. We feel very comfortable offering 2 4-hour, even 6-hour treatment options for older patients now, and we seem to really use this as really our standard for these older patients that present to our hospital. Avoidance of exceeding 24 milligrams of TPA in a stable patient, I think that's a good lesson to adhere to. Is stick to the protocols. There's really not much need to exceed over 24 milligrams. And again, as we mentioned before, consider same-day out of ICU transfer after completion of the OPTALYSE protocol.